So hello friends and welcome back to the channel. I'm Dr. Mohsin Raj. I've done my DM cardiology from AIIMS New Delhi, and through this channel and through multiple videos I've been teaching you on important ECGs. And in the previous video we have discussed the critical ECGs that every student, MBBS student or every physician or resident doctor should know. And the reason being that if you are a student, it will help you in exam questions. If you are a practicing doctor, it will help you in managing critical patients. Now, many of you wanted to know the treatment strategies of those ECGs. So now you know ECG recognition is a pattern recognition. I've told you that. Now, once you know those patterns, once you recognize those ECGs, how do you treat those patients? What should be a line of management? That is what we're going to talk in this video. So remember, and I'm going to briefly touch upon the patterns that I talked about. The first ECG that was there in the video was that of ST elevation MI. Now, if you're a beginner in true sense, you may have a hard time to see where is the ST segment elevation. What are you talking about? What is ST segment elevation MI? So remember, this is the point, that's the start of the QRS complex. It would be the onset of the Q wave. This segment, prior to that, this would be the baseline of the ECG, right? So remember, your ST segment elevation or depression will be with respect to this particular line, this PQ segment, okay? This part between the end of the P and the onset of the Q. And then this point, that's the end of QRS complex. This is the J point. And that marks the onset of the ST segment. So you compare the ST segment with this baseline. So clearly this is up, it's elevated. That's what I mean by ST segment elevation. So compare it to the baseline. This segment is elevated. This is ST segment elevation MI. This is a pattern that every doctor, even if you're a surgeon, you should recognize this. Okay. Then I talked about these two ECGs. I've showed this in the previous video. I'll give you the link of that video in the description. So this is, as I mentioned there, ST elevation. Look, ST segment is up, up, up in the inferior leads 2, 3 and AVF. You have reciprocal depressions in the mirror image leads, that's leads 1 and AVL. And you have subtle depressions in V1 and V2. So I told you this is inferior wall, ST segment elevation MI, inferior wall STEMI. Another ECG in that video was this. So you have ST segment elevations in the anterior precordial leads V1 through V4, even V5. And you have depressions in the reciprocal inferior leads. Remember, you have ST elevation, and if you have elevation in the anterior leads, you will have depression in the reciprocal inferior leads. If you have ST elevation in the inferior leads, you will have reciprocal depressions in the high lateral leads, that's 1 AVL. And now, primarily focusing on the management of these patients. So if you are an intern, if you are an MBBS doctor posted somewhere and you get to see these patients, now what drugs will you give in emergency? You will give them loading of the 2 antiplatelet agents. You will give them the loading dose of aspirin. You'll give them the loading dose of clopidogrel. You will give them the loading dose of atorvastatin, any statin, atorvastatin. So you'll give them 300 milligrams of aspirin, 300 or 600 milligrams of clopidogrel, depending on whether the patient goes for thrombolysis or he goes for a primary PCI, and you give him atorvastatin 80 milligrams. You give him oxygen only if the saturation is less than 90%, okay? If he's having severe pain of myocardial infarction, you give him intravenous opioids. In case of right ventricular myocardial infarction, you should be able to recognize that in inferior wall STEMIs, they may have right ventricular myocardial infarction, then giving IV fluids is of paramount importance. Then please do not give that tablet sorbitrate, that's long-acting nitrate, to patients with MI. Okay? If at all you need to give nitrate, it has to be nitroglycerin, not the usual tablet that patients of coronary artery disease usually take, the sorbitrate. Don't give that patient. Especially, you do not give any nitrate to someone who has inferior wall MI plus right ventricular MI. And then your major question is, once you've done the loading doses, once you've given him aspirin, clopidogrel, you've given him atorvastatin, you've given him some pain relief medication, your next most important decision is, how do I revascularize this patient? Now remember, if you are working in a hospital that is, a PCI capable center where you have cardiologists who have cath labs and they do primary PCIs, then the best treatment for that patient is emergency primary PCI. However, if you work in a center where either you don't have a cath lab or the cath lab is not operational all the time, then thrombolysis, okay? So you decide on the mode of revascularization and anticoagulation. Remember, if your patient is, now you've decided that the patient goes for primary PCI, your job actually ends here. You give him aspirin, clopidogrel, statin, you shift to the cath lab, then it's up to the cardiologist. He will give heparin during the procedure of primary PCI. That's all anticoagulation, that's all that the patient needs. But if the patient, if you're managing by thrombolysis, then you need to give him anticoagulation at least for 48 hours or preferably throughout the hospital stay, or till he undergoes PCI if at a later time. Now remember one important thing, if the patient has hypotension, shock, so STEMI with shock, STEMI with failed thrombolysis, there are criteria now to define whether thrombolysis succeeds or not. So remember, it's not all the time you give thrombolysis that's going to succeed. Maybe the ST elevation never comes down, maybe the pain never gets away. So in that situation, you better refer the patient to another center that is capable of primary PCI. So remember, STEMI with shock, refer for primary PCI. STEMI with failed thrombolysis, refer for primary PCI. Rescue PCI, we call that. Now, some important questions that may come in entrance exams, these times. You know, what is your time, this first medical contact or door to wire time, door to needle time, these things. If the patient presents to a hospital that is PCI capable, then remember your goal is to cross that lesion, that occluded lesion with the coronary wire in 60 minutes, less than 60 minutes. If the patient initially presented to a non-PCI center, then he gets referred to a PCI center, then your aim is less than 90 minutes to wire crossing. If you decided that you will thrombolize this patient, then you should give this thrombolytic agent within 10 minutes of diagnosis. That's less than 10 minutes. That's the time, the cut point that the guidelines have advised. Now, which thrombolytic agent you use, whichever is in your hospital. If it's streptokinase, use streptokinase. The dosage you can easily find in any book. Alteplase, reteplase, tenecteplase, whichever is available. Obviously, these bolus thrombolytic agents, tenecteplase, reteplase, they're better, they're superior. Why? Because you can understand they're fibrin specific and they have a superior rate of patency of the coronary artery. They are better in lysis, more efficacious agents. But if you have streptokinase, if that's the only agent you have, you use that agent, okay? The next set of ECGs I showed you in that video were that of high-risk NSTEMI. So now remember, NSTEMI is myocardial infarction, but you don't see the typical ST elevation on the ECG. But remember, some of these patients may be very high risk. Some of these patients may have very high risk coronary anatomy, so you need to identify those patients so that you refer those patients timely for a PCI, for coronary angiography. Now this was the ECG that I showed you, that you have ST elevation in the lead AVR. You have ST elevation in the lead AVR and you have diffuse ST segment depressions in the other leads. So whenever you see this ECG, ST elevation in the lead AVR and diffuse ST segment depression in the rest all other leads, this should raise that red flag. This patient likely has either disease of left main coronary artery or disease in all three coronary arteries, or at least a critical disease of the proximal LAD artery, which is a very important artery. The second pattern I want you to recognize is the so-called valence pattern, where you have valence type A or valence type B pattern, where especially in the leads V2, V3, you may have these changes even in V3, V4, V5. You have biphasic T waves. See, the ST is not up. The R waves are preserved, okay, but what you have is the abnormal T wave. The T wave is having a biphasic pattern, a positive followed by a negative deflection. In a patient with a history of chest pain, he may not have chest pain at present, but history of chest pain with this dangerous looking ECG, you should plan for early coronary evaluation, because what we know is that most of these patients have critical occlusion of proximal left anterior descending coronary artery. Then these deeply inverted T waves in these leads V2, V3 or maybe V4, V5, this is known as valence pattern B. Again, these patients, these signs, the valence syndrome, this is what is known as valence syndrome. It's highly specific for a critical disease of LAD. You need to know this, okay? So you refer these patients for early PCI. They're not candidates for thrombolysis. No, you refer these patients to centers capable of PCI. Then I showed you this ECG where you had to identify these tall and peaked T waves. I told you this is hyperkalemia. Even QRS has broadened out, okay? Then with further elevation of serum potassium levels, I told you the QRS becomes really bizarre. The QRS is stretched out. Okay, the QRS is widen, bizarre, P waves disappear, T waves are tall and peak, all gets merged together, and this predisposes to dangerous ventricular rhythms, and the patient can die unless you stabilize this patient by treating hyperkalemia. Now, you can read hyperkalemia management in any book, Harrison, Indian books, internet, everywhere it will be written that a patient with hyperkalemia, severe hyperkalemia, having ECG chains, you need to give some agent to stabilize the membrane. The membrane of the cardiac muscle cells is highly irritable with a potassium of more than 6.5. Okay, so then at that point you need to stabilize with calcium gluconate. You give them intravenous calcium gluconate. Dosage easy to remember, 10 ml of 10% solution, intravenous push. Okay, so why? Because it stabilizes cardiac membranes. Okay, so this is the agent of choice, the first drug you give to the patient, the first thing that should come to your mind, IV calcium gluconate. Okay, then for other patients, for all other patients, irrespective of whether they have the ECG chains or not, but with dangerous potassium levels more than 5.5, you give them you give them a combination of insulin and dextrose. Again, the protocols differ. This is from Up to Date. You can see that a common regimen that they advise is you give 10 units of regular insulin, and then you follow that by 50 ml of 50% dextrose over 5 minutes. That's what you give. The next step is to give things that remove potassium from the body. This is a patient with acute kidney injury, end-stage renal disease, somebody known with kidney disease on dialysis. You just need to dialyze and remove that excess of potassium. Or is somebody who is non-oliguric or is on is maybe a heart failure patient. You give loop diuretics to expel that potassium in the urine. You frequently use these potassium binders, those K-bind sachet, to remove the potassium via the GI tract. Okay. The next ECG was this ECG. I told you here everything looks normal. There's no ST segment elevation, there's no ST segment depression, there's no heart block, nothing much. But then the QT interval is very much prolonged. I told you that this is, it can have so many etiologies, and the answer to this patient is you treat the cause. Look for the cause, treat the cause. If the patient is hypokalemia or hypomagnesemia or hypocalcemia, treat that. If the patient is myocardial ischemia, remember this QT prolongation is an important sign of myocardial ischemia. QT prolongation, torsades, deponts that this dangerous rhythm predisposes to, myocardial ischemia is an important cause. So if the patient is having chest pain, QT prolongation, that means this patient has myocardial ischemia and you need to act accordingly. Call the cardiologist, get him to the cath lab and things like that. Treat the reversible causes, and then look for, in fact, even before you actually do other things, you look for any reversible causes, any drugs that cause QT prolongation. You need to be aware about which drugs cause QT prolongation. So know those drugs, treat the reversible causes, including electrolyte abnormalities, including withholding any particular drug that may be responsible. Treating myocardial ischemia if patient has ongoing angina. If nothing is there, then possibly the patient has congenital long QT syndrome, right? Remember, this ECG may look benign, the heart rate is okay and everything seems okay except this QT interval is prolonged, but remember this predisposes to dangerous polymorphic ventricular arrhythmia. Polymorphic VT in the state of prolonged QT, that's what's called torsades deponts, lethal arrhythmia. Lethal arrhythmia, and an MCQ on that, drug of choice, magnesium sulfate. You may have to pace these patients with a temporary pacemaker to increase their heart rate. With increase in heart rate, the QT interval shortens. Next, I showed you this ECG. I told you that you should just remember it for your lifetime. That you have S waves in the lead 1, you have Q waves in the lead 3, you have T inversion in the lead 3. This is S1, Q3, T3, and in a right setting, in a patient in whom you're suspecting acute pulmonary embolism or right heart strain, this is a highly specific ECG. It may be there in only 10% of the cases, but this is a highly specific thing for highly specific ECG sign, S1, Q3, T3 sign for pulmonary embolism, an important spotter in your exams, right? Now, what is the investigation of choice in these patients? It is CT pulmonary angiography. Call your radiologist, get a CTPA done. Somebody who's unstable, you can't shift him to the cath lab, call the cardiologist, get an echo done to look for right heart strain. right? Now, the treatment is thrombolysis, but whom do you thrombolize? Not everyone with pulmonary embolism needs thrombolysis. Only high risk pulmonary embolism or massive pulmonary embolism, that's what you call it, needs thrombolysis. And what is by definition massive or high risk pulmonary embolism? It's the patient with hypotension, it's the patient with shock, it's the patient who gets a cardiac arrest because of pulmonary embolism. Not someone who just has some other signs, maybe chest pain, has thrombus in this on the CTPA. Not everyone needs thrombolysis. Okay, only high risk or massive PE when the patient has hypotension and shock needs thrombolysis. The agent that commonly is used is alteplase, 100 milligrams over 2 hours. Remember, anticoagulation, everyone. See, not everyone needs thrombolysis, but everyone gets anticoagulation. Okay, you look for the precipitating cause, okay, and that determines the duration of anticoagulation. And what do you do in patients in whom there's contraindication for thrombolysis? Remember, whether you're doing thrombolysis for STEMI or you're doing thrombolysis for stroke or you're doing thrombolysis for pulmonary embolism, you should memorize that list of contraindications to thrombolysis, right? That will appear as an MCQ in INICET or whichever exam, even the super specialty exams, wherever you're appearing, you should memorize that list, or at least if not the exam, you should memorize that list for your patients, right? But like, for example, if someone has a past history of CNS bleed, you can never thrombolize that patient. If somebody has had a recent head surgery, CNS surgery, you cannot thrombolize those patients, right? Severe uncontrolled hypertension, you cannot thrombolize those patients. So you need to know those contraindications of thrombolysis, and then in those cases, what do you do? If you have a patient with pulmonary embolism, the patient has an absolute contraindication of thrombolysis, that's the time you call either your CTVA surgeon for embolectomy or again a cardiologist for catheter-directed thrombolysis. Okay. The next ECG in that video was this ECG, where you have one QRS complex which is short, other QRS complex which is tall. This is known as electrical alternance, that is beat by beat alteration of QRS amplitude. And this electrical alternance is suggestive of pericardial tamponade. So this ECG should make you think of pericardial tamponade. Remember, what you remember about Beck's stride? That can be an independent question. So in this patient, you should look at the jugular veins, look for jugular venous distension, look for pulsus paradoxus, right? And look for muffled heart sounds. So remember, the investigation of choice in tamponade is echo. Look at the fluid around the heart. Look at the compression caused by that fluid in the cardiac chambers. Look at the signs of pericardial tamponade on echocardiography, and the treatment is pericardiocensis. Remember, investigation of choice. Remember the Beck stride of tamponade. Remember the electrical alternance of tamponade. Remember the investigation, the echocardiography, and remember pericardiocentesis. Now, not everyone can do pericardiocentesis. It's a very dangerous procedure. At least go to YouTube, watch teaching videos on pericardiocentesis. The most common approach is subcostal approach, right beneath the xiphoid process. The needle is guided at around 45 degrees to the body surface. It is directed towards the left shoulder. This is a blind approach. We do it under the guidance of echocardiography, we do it under the guidance of fluoroscopy, but if required in a bedside, in an emergency situation, this is done blindly through this approach. Next ECG was this again. Please never forget this ECG. Somebody with history of syncope, with this ECG, where you see there's no correlation between P waves and the QRS complexes. The P waves are beating on their own. The atria is beating on its own rate. Ventricles are beating on their own slower rate. This ECG has bradycardia, AV dissociation, and ECG of complete heart block. This one is pretty easy to recognize. P waves not conducted, P waves not conducted, not conducted, not conducted. An escape beat comes, not conducted, not conducted. What do you do in this situation? Rule out reversible causes, especially potassium abnormalities. Okay, rule out reversible causes. Then remember, the reversible causes are treated. This ECG, okay, the patient needs pacemaker. Even if the patient is asymptomatic. Complete heart block needs pacemaker even if the patient is asymptomatic. Okay. Now remember, if it's the middle of the night, you have to decide, whether to put a temporary pacemaker till the morning comes and the cardiologist puts a permanent pacemaker. That's based on this. If the patient is having recurrent syncope, if the heart rate, if the escape rate is less than 40 beats per minute, if the QRS escape is wide. Look at the QRS complex. This is, see, the heart rate is less than 40. The QRS is pretty wide. It's more than 120 milliseconds. This patient needs a temporary pacemaker before a permanent pacemaker. And then, of course, the definitive treatment for a complete heart block, even if the patient is asymptomatic, is permanent pacemaker. Next ECG, I told you, regular narrow complex tachycardia. What's your differential diagnosis? Number one, it is supraventricular tachycardia, an SVT. It could be an AVNRT, it could be AVRT. But the thing is, it is supraventricular tachycardia. Simple thing, a pattern recognition. It is tachycardia. It's more than 100. It's more than 100. It's regular, and the QRS complex is narrow. You're not able to appreciate P waves here. Please, SVT. Okay. And how do you manage this patient? The treatment, the first line treatment is vagal maneuvers. Vagal maneuvers and IV adenosine. You should tell your patients to do this. Blow out, keeping your nose closed, right? Try to exhale, but not exhale exactly. Or you give them a syringe and then a straw, an occluded straw. Just ask them to exhale without actually exhaling. Just try to exhale against a closed glottis. That's what they call a Valsalva maneuver. Sorry, a vagal maneuver. This is one of the vagal maneuvers. Some people advise cold water, different vagal maneuvers just to stimulate your vagus nerve. Or you give IV adenosine. That's your drug of choice for SVT. If it comes as an MCQ, the drug of choice is IV adenosine. Step number one is vagal maneuvers and IV adenosine. The dosing is here, 6 milligrams of rapid IV bolus. If it doesn't work, then in 1 to 2 minutes you can repeat a higher dosage, 12 milligrams. So dosing is 6 milligrams, doesn't work, second bolus is 12 milligrams. Sometimes you even go up to 18 milligrams. That has been used. If the patient is hemodynamically unstable, adenosine doesn't work, synchronized cardioversion. If the patient is hemodynamically stable, his blood pressure is okay, and adenosine doesn't work, then the next choice of drugs would be beta blockers, things like IV metoprolol or IV diltiazem, IV verapamil. Okay, if they don't work, then anyway synchronized cardioversion. So these are the different ways you can treat adenosine. You can treat it with vagal maneuvers, you can treat it with adenosine, you can treat it with beta blockers, you can treat it with calcium channel blockers, or you can treat it with synchronized cardioversion. But the agent of choice that the MCQ wants you to know is adenosine. The next ECG, again, tachycardia, narrow complex tachycardia, but it's irregular. I told you this is atrial fibrillation. Okay. So regular, irregular, narrow complex tachycardia. You think of atrial fibrillation. Now, I won't go into the details of this. If this video will become too lengthy, then it will bore you up. So remember 3 things in an atrial fibrillation patient. You need to prevent stroke. Atrial fibrillation predisposes to stroke. Okay, you need to prevent stroke, so you need to give anticoagulation. That's step number 1. Anticoagulation. There's a mnemonic for this: A, B, and C. Anticoagulation. Second is better symptom control. How do you control these symptoms? You control symptoms by either slowing down this tachycardia, that's the rate control, or you just convert this abnormal rhythm to normal sinus rhythm. That's rhythm control. So either rate control, control the heart rate, or rhythm control, convert this atrial fibrillation to sinus rhythm. Okay, then C stands for comorbidities. These patients have comorbidities: hypertension, diabetes, heart failure, and other things. Just control these comorbidities. So that's the mnemonic of treatment for atrial fibrillation. And then a question that might be asked: so who do you cardiovert? Remember, if the patient is hemodynamically unstable, the treatment of choice is emergency cardioversion. Emergency cardioversion. Remember, if they describe a patient in an exam or in your real clinical scenario, somebody with hypotension, somebody with dizziness, hypotension, ECG having atrial fibrillation and a very fast ventricular rate, what do? You cardiovert that patient. Okay. On the other hand, if the patient is hemodynamically stable, he's having AF, he's having atrial fibrillation, but he's hemodynamically stable, then there's an important thing that comes before you think of cardioversion. That's anticoagulation. Remember, when your atria are fibrillating, there's stasis of blood in the atria, especially the appendage area of the left atrium. You get a clot there. And then once you cardiovert these patients, once you convert them back to sinus rhythm, those little clots can get embolized into the brain and they are predisposed to stroke. So that is where you need to think of anticoagulation. So you immediately start anticoagulation. If the patient has been on anticoagulation before he presents to you, then you can think of cardioversion. But otherwise, in a patient who is having atrial fibrillation of duration more than 48 hours, or in most of the cases you don't know the actual duration, right? So you need to give them anticoagulation before you think of cardioversion. And remember, you need to give anticoagulation for at least 3 weeks before you think of cardioversion. And remember, cardioversion is not just electrical cardioversion, DC cardioversion. You can use drugs to cardioversion. Most commonly use amiodarone for cardioversion or other similar drugs. So remember, the treatment of AF, you think of anticoagulation, you think of stroke prevention, you think of symptom control, which is either by rate control, you use beta blockers for rate control, you use calcium channel blockers for rate control, or you think of rhythm control. For that, we can use drugs. We have different antiarrhythmics to use that to treat atrial fibrillation, or you can use cardioversion. And remember, 3 weeks of mandatory anticoagulation before you think of cardioversion in a stable patient. The other alternative is you do a transesophageal echocardiography, look for a clot in the left atrial appendage. If it's not there, then they don't need 3 weeks of anticoagulation. You can go ahead with rhythm control. The last ECG that we'll discuss is this ECG, wide complex tachycardia. Remember, tachycardia, narrow complex, regular, it's SVT. Tachycardia, narrow complex, irregular, it's atrial fibrillation. Tachycardia, wide complex, regular, most of the times it is VT. It is VT most of the times, okay? And another clue I told you was this AVR, which is positive. Extreme axis, AVR positive means northwest axis of an ECG. So this is ventricular tachycardia. Remember, treatment of choice is cardioversion. If the patient is hemodynamically unstable, no doubt, cardioversion, DC cardioversion. If the patient is stable, still the treatment of choice is cardioversion. Then if you don't want cardioversion, if it's not available, you want to know a drug that can be used, the first choice drug is procainamide. It's not available easily. The agent that we commonly use is IV, intravenous amiodarone. Okay, so remember, treatment of choice, cardioversion, even if the patient is stable. Okay, if you want to use drug, the drug of choice is procainamide. The drug that's commonly used, is easily available, is amiodarone. Now, what's the dose of amiodarone you need to use? If this patient has cardiac arrest, no pulse, cardiac arrest, 300 milligrams is the dosing that's recommended. If the patient is stable, talking, pulse is there, but has a VT, which is stable VT, okay, 150 milligrams is the dose. Then you give them an infusion of 1 milligram per minute, that's 60 milligrams per hour for 6 hours, then another 30 milligrams per hour for 18 hours, and then you switch to oral, again a higher dose for the first couple of weeks, 400 milligrams twice a day, and then you slightly decrease the dose to at least possible like 200 milligrams a day of amiodarone. And you need to, now look, I may have talked about so many things on this video, but the truth is that you need to go to an emergency. You need to go to emergency department in your MBBS postings and see how they use adenosine, how they put the cannula, how they put the three-way, and how they give adenosine to patients. You need to go to the emergency department to see how they do pericardiocentesis. You need to go to the emergency department to see how they do cardioversion in a life-threatening ventricular arrhythmia. Okay, so videos are there for the exams, videos are there for you to know things, to give you knowledge, but you need to go to your departments, medicine, emergencies and all, to actually know the treatment of these diseases. I hope this video has been useful. Do like, subscribe the channel. Thank you.